My name's Qasim Chowdary. I work in the National Tobacco Control Team at Public Health England. And you'll see from the agenda that next to my presentation slot, it just has a very, very broad title that says National Work. And it was one of those situations where this was months and months ago it was being planned, and I was thinking, what's the loosest title that I can give, which just gives me a free rein to rock up and give you an overview. Is this the clicker? This is the clicker. So a couple of things to mention before I start the presentation. So I know Joanne McDonald from NHS England, a senior nurse from NHS England, really wanted to be here today and has contributed a significant amount of work to this agenda as part of the Leading Change Adding Value programme. And it's unfortunate that she can't be here, and she does send her apologies. What I'm going to do is spend the next 30 minutes or so. I understand there's some rigorous timekeeping going on, so I get a 5-minute warning as well, right? Okay. I'm going to spend about 30 minutes or so giving a somewhat of a kind of public health purist, bit of statsy kind of overview of prevalence, kind of sweeping tour of what's happening at a national level from a policy and government point of view, and then think about how that translates into the real meaningful work that's happening at a local level. I would say also that the vast majority of my work in the tobacco control team is focused on smoking and mental health. The way our kind of team separates its work out is to think about where we'll have the maximum public health gain. And I think you'd be hard pressed to find a population where such significant improvements could be made. Hopefully my presentation will kind of reiterate that case somewhat. So, are the slide sets going to be shared afterwards? Do you know, yeah? So permission to share these. And what I've done here is hyperlinked all of the various bits of policy and guidance. And this is not all of the guidance that's available. But what I want to kind of point to here is the fact that there is a very, very strong consensus at a national level across a number of different organisations where they've either put a position statement out, put guidance out, put case studies out. So the last three here are case studies here of trusts that have implemented smoke-free, the CQC guidance. And in various iterations of these documents and the various presentations of them, what you'll find is pretty much consistent across the board, is the extent to which it gravitates towards the NICE guidance, PH 48, published in 2013. And if anything, most of these are kind of extensions of that or presentations of that guidance. But there is a very, very strong consensus and interested parties who have spoken out about the need to address smoking in particular amongst people with a mental health problem. So when we look at it from a purely tobacco control purist perspective, and when we look at where we are now and how we got here, there are plenty of things to celebrate in tobacco control. Smoking rates have declined amongst the adult population steadily year on year, and fallen faster amongst young people at the age of 15. So this chart shows the average decline in smoking prevalence from the year 2000 to 2016, and we're currently at 15.5% smoking prevalence in the general population. And when you look at the range of tobacco control interventions that are in place, we kind of take it for granted a little bit, but if you think about a 15-year-old growing up today, they're growing up in a very different environment to a 15-year-old that was growing up 20 or so years ago. And there have been a range of policy, legislative, treatment offers available that have been introduced and sustained in England, which have helped us to get to the second lowest smoking rates in Europe. Now, these are the things like the smoke-free ban in public places, point of sales display ban, things like plain standardized packaging, for example, at a national legislative level. But also we've had stop smoking services for a number of years too, who have been treating smokers in local areas since the late 90s and the early 2000s. And it's that kind of comprehensive legislative policy at a national, regional and local environment with a treatment offer, which have contributed to these low smoking rates and the recent declines. Now, this should not be a shocker to anybody in the room, but when we speak of declines of smoking prevalence in the adult population, there's a bit of hissing on the microphone or a speaker. Oh, it's the heater. Oh, okay. So what I would say is there's plenty of things to celebrate in tobacco control, but we have to be honest about the failures which exist. And one of the biggest things which is unforgivable is that we have not seen a similar or sustained decline in smoking prevalence among people with a mental health problem. So the data itself, just on smoking prevalence, is patchy and not either reported as frequently as other populations or at the same level of quality. And that's a major problem that we're trying to sort out. But from the data available, when you look at the reductions in smoking prevalence amongst the general population and people with a mental health problem, there's not been any sense of a decline. Rates remain stubbornly high, and inequality has widened. And that is not the goal of any public health initiative, be it at a national or local level. Now, I'll explain this. So each dot on this chart represents a local authority area. And we have vertically smoking prevalence in the adult population, and across the bottom we have the smoking prevalence in adults with a serious mental illness. So the data here comes from primary care records on GP databases, and every single dot represents a local authority area. So when we look at the national data, combined averages of these data, the prevalence of smoking among people with a serious mental illness is 40.5%, compared to the national average, 15.5%, which I showed you in an earlier chart. But the thing to think about with this specific presentation of the data is that even in areas where you might have lower adult smoking prevalence in the general population, you will still have almost double the prevalence in the population of people with a serious mental illness. So the inequality at a local level is stark, the inequality at a national level is stark, and even in areas where you might compare better than the national average and say, well, our adult population has relatively low smoking prevalence, it does not mean that every subpopulation in there has a low smoking prevalence. So I suppose the key thing to note about that is the point about identifying which populations in each local area need to be prioritized, and even if there's an assumption that smoking is dealt with in our local area, chances are it's not. Okay, so I've got the sources at the bottom as well, which are all hyperlinked, and I encourage you to look at the documentation that accompanies these stats and figures. So this is from the Stolen Years, very, very comprehensive publication published by ASH in 2016, which took a very robust and comprehensive snapshot assessment of smoking and mental health quite broadly, and came up with a significant number of recommendations. Strongly encourage colleagues to read it. And what we see here is in the opening line of the executive summary of ASH, and even in the tobacco control plan, which I'll talk about a little bit in the subsequent slides, we talk consistently and frequently about the 10 to 20 years preventable premature mortality and the difference in life expectancy that people with a mental health problem have compared to the general population. And what we see from these stats here is that as smoking prevalence increases, most commonly associated with the severity of mental health problem, so does the average reduced life expectancy amongst that population. And unfortunately, it might not be a shocker that the more severe the mental health problem, the higher smoking rates you generally see. And here's another analysis of other data which shows, again, the inequality across the spectrum. So I say the 40.5% smoking prevalence among people with a serious mental illness, they are in primary care settings in the community. What we tend to find from the data available is that when you look at inpatient settings, you're looking at prevalence rates ranging from 60, 70, and even 80%. So coming on to government's position, if you want a very, very, very quick read, which neatly and concisely synthesizes government's position on smoking and mental health, there are 5 paragraphs in the Tobacco Control Plan for England which really, really crystallize it. So tobacco control plans in England, which one are we on now at the moment, Russ? Probably our 4th. Russ and I were talking earlier about how long we've been in tobacco control for. So I'm celebrating 10 years in February. I say celebrating, I don't know whether that's the right term. I'll leave Russ to disclose how long he's been in tobacco control for. But we're on our, 4th or 5th tobacco control plan?
I've lost count.
Yeah. So what we've had is successive government tobacco control plans which say, this is the scale of the problem and this is what we're going to do about it. And they contribute to kind of galvanizing and kind of getting networks to coalesce at a national, regional and local level around some common themes. And the Tobacco Control Plan published in July 2017 aims to do exactly that again. But for the first time ever, mental health is front and center in the Tobacco Control Plan. So it's in the foreword, talking about the inequality between and mentions the 40% prevalence in the population of people with a serious mental illness. But there's an entire chapter. And what I am going to do, which I don't often do, is just read the 5 paragraphs from the chapter. Because like I say, it very, very neatly summarizes government's position. Can I check how I'm doing for time? Okay, brilliant. Okay, so 5 paragraphs, so bear with me. Smoking prevalence may be declining year on year nationally, but in our journey towards a smoke-free generation, we risk leaving some people behind. 40.5% of adults with a serious mental illness smoke, and people with a mental health condition die on average 10 to 20 years earlier than the general population. Smoking causes premature death, disability and poverty, and if we do not reduce smoking prevalence among this group, we will have failed to reduce inequalities. People with mental health conditions want to quit smoking as much as other smokers do, yet health professionals can be reluctant to offer them stop smoking support. Some professionals mistakenly believe that stopping smoking could negatively affect their patients' mental health, when it can actually reduce symptoms of anxiety and depression. People with mental health conditions have an equal right to be asked whether they smoke. They need to be offered effective methods to quit smoking or reduce harm as part of their care plan, and there is urgent clinical need to improve the support they receive. In some instances, healthcare staff will escort patients on and away from hospital grounds to smoke. This practice is outdated. It reduces resources available to deliver clinical care and causes direct harm to patients. And then the following paragraphs talk about government's ambition for smoke-free trusts by 2018, and the need to not just address smoking in inpatient settings, but if we're really, really going to reduce those prevalence figures, we need to look at addressing smoking in the community as well. So very, very kind of challenging language there. I would say one that holds a mirror up and says we haven't reduced inequalities. Inequalities has widened. It alludes to there being some practices that are outdated, but also we know, and we'll cover a little bit later on, that the tide is shifting a lot, I think. So we have, in the Tobacco Control Plan, a commitment to just improve data. If we had a regular national indicator that we report on, or was made publicly available, I think that would have read differently. That would have been an ambition to get to a certain prevalence of smoking by a specific year. But like I said a little bit earlier, the data is not available in such a way where we could do that. And then the second ambition is for smoke-free inpatient services by 2018. So I read the first few paragraphs from the tobacco plan, but the plan, when it talks about smoke-free by 2018, goes a little bit further than previous articulations of this ambition. And it's something that we kind of battle with day in, day out in tobacco control, not just in mental health settings, but more broadly when thinking about the NHS going smoke-free. Because there's a common misconception that smoke-free, because of the language used, reminds people of the smoke-free legislation ban. And there seems to be a convenient assumption that then follows, which is, well, this is about the trust grounds being smoke-free. This is about us saying, beating our chests quite proudly and saying this is a trust where no smoking is allowed, and if you want to smoke, you have to go away to the other side of the perimeter. There's going to be very little public health gain by shoving smokers to the other side of the fence. The nice recommendations that we referred to, there are 16 recommendations in there. Number 16 is smoke-free premises. The 15 before it are about treatment. They're about providing a range of pharmacotherapy and stop smoking options for when people come in. They are ultimately about dealing with a very, very difficult chronic relapsing addiction to tobacco smoke in a sympathetic and a considerate way. And this is what's referenced in the tobacco plan. It's not about telling people where they can and can't smoke. It's about dealing with it in a considerate and a sympathetic way. So what does it say here? For any hospital setting, becoming smoke-free is more than simply telling patients, staff and visitors where they can and cannot smoke. It's about trust working to end cultures in which smoking is used as a way to build relationships with patients, or whereby cigarettes and smoking breaks are used as incentives and rewards. It also includes increasing the availability of a full range of evidence-based treatment options to support quitting or temporary abstinence for patients and staff, and encouraging staff to act as role models. So we know that not everybody that's going to come in is going to want to make an active quit attempt. And this isn't about saying everybody that comes in has to commit to a non-smoker's identity. It's about saying, when you come in, know what to expect. As part of your clinical care, we will offer you a whole range of treatments which will help with your addiction to tobacco smoke whilst you're here. We hope that that behaviour is sustained when you leave, but whilst you're receiving your clinical care, this is what you can expect from us. And this is a flashy graphic which kind of says that, which we have published on one of our PHE blogs. But when I don't know how familiar you are with Duncan Selby's Friday message. forward it on to everybody, do you? So Duncan speaks very passionately about smoke-free, both in mental health settings and acute. And in communications like that, you have to kind of distill some of the key themes. And the three here are, you'll see them in things like Duncan's blog posts and when he's doing an interview. But it's about, basic stuff, asking patients if they do smoke. Is that information being recorded? Do trusts know the proportion of patients who are where smoking status is even recorded in the first instance? Because if you don't know the scale of the problem, you don't know then how much of it needs to be addressed. How easy is it? I mean, put yourself in the eyes of a person being admitted, for example, who is a smoker. When they come in, how quickly will they receive a stop smoking aid in their hand? Will it be a fast-acting nicotine replacement therapy? Will they have access to more than one product? And that's kind of what we are trying to communicate from Public Health England through various NHS England programs. This kind of smoke-free agenda is really about. Like I say, these reductions in prevalence will not happen if we do not make the full range of treatment options available, and it's standard part of clinical care. So part of making it standard part of clinical care, we are working with NHS England on, I would say, three high-profile programs, which I'm going to talk about in the next three slides. So the one that you're probably the most familiar with is the sequin, and the risky behaviours sequin, which Public Health England, so the tobacco control team along with the alcohol team, are working together to support the implementation of the sequin, having advised on the components of the sequin that should be in the specifications in the first instance. And it's a stripped out component of the NICE guidance, and it's the Ask, Advised, Act model, which we know is effective in triggering quit attempts. And we know is effective in identifying people who smoke, whether they want to quit or not, or whether they just want to temporarily abstain, in opening the doors to effective offers of support. So you'll see here, if you haven't already, the 3 steps to Ask, Advise, Act, and what we sometimes refer to as very brief advice. And there is, like I say, 3 steps. So asking the patient if they smoke, advising on the best, so if they are a smoker, advising on the best methods of cessation or temporary abstinence, and then acting on the patient's decision, having presented the options available to the individual. Time check. 10 minutes. Okay, better hurry up. Another program, NHS Right Care, possibly less familiar, is another program that we are working on, and it's not necessarily a secondary care facing program. It's a program which is primarily CCG focused, and it aims to assist informs local decision making. So as part of this suite of tools, NHS England have produced data packs, intelligence tools at a local CCG level, so that commissioners in local areas can think about the extent to which they understand their local population and the extent to which interventions are going to return the biggest health gain, but also be cost effective. Now, most of the time, whichever way you look at smoking cessation interventions, they come out time and time again, and you can look at the NICE return on investment website, they come out time and time again as being one of the most effective clinical interventions you can deliver, which will return significant public health gains. That's very brief advice, but also behavioural support alongside a stop smoking aid. And as part of the NHS Right Care programme, we are working with them to ensure that stopping smoking or smoking cessation interventions are embedded in every single treatment pathway. So they recently published a COPD treatment pathway, which has smoking cessation interventions in there. And they are about to publish a CVD in people with SMI pathway as well, which we've been working with them on as well. So things to be mindful of that are happening in other parts of the system as well. One of the resources that we produced alongside the suite of tools is something called a patient decision aid. In fact, if I go back to the first slide, I hope it's hyperlinked. Oh, smoking cessation decision aid here is hyperlinked. And what that is a document which aims to list the various options available to a smoker in as easy language as possible. So if somebody's thinking about making a quit attempt, they could go cold turkey. They could use alternative therapies. They could use a stop smoking aid like pharmacotherapy. They could seek behavioral support. They could use an e-cigarette. They could cut down. There's a whole different array of options that would be available to an individual. And what this decision aid does is aim to synthesize the evidence available and look at the various probabilities of success and outcomes associated with those. So it tries to give a balanced view of the different options available and what to expect, not just success-wise, but what to expect with respect to how it might assist a quit attempt, any side effects, things like that. But it kind of gives a balanced, overarching perspective of all of the different options available. So strongly encourage that's it, 5 minutes. Okay. I think I'm towards the end. Third program, which you might be more familiar with, is Leading Change Adding Value. And that's a specific targeted piece of work to support trusts to implement smoke-free, the NICE guidance, which you spoke about earlier in your first slot. And that is a piece of work where we recruited 8 trusts in the south of England. Most are probably in this room at the moment. And we really unpicked the detail on the extent to which the NICE guidance was being implemented, but not in a method where it was kind of like a national audit or a point and blame exercise. One of the things that we're very keen to do from Public Health England is just facilitate understanding the things that are working well, the things where improvements could be made, facilitating peer-to-peer knowledge and experience. And I think leading change, adding value, at least from my experience, and I'd be happy to hear other people's experience, allowed us to do that, whereby, and I'll explain these graphs. So when somebody goes through what we call a mental health deep dive self-assessment, in essence what they're doing is they are unpicking the various elements of NICE guidance implementation and saying, well, we've achieved somewhat here, we haven't really made much progress on this theme, but we think we can do a significant amount more. And for things like training, for example, we've got a comprehensive training package. And then what it offers up is scores, but also a qualitative narrative as well. And like I say, trusts in the south went through this exercise, learned from the experience, kind of teased out. It's a method whereby the subsequent actions from going through this process naturally kind of fall out of it when you start asking questions, say from your pharmacy leads or your communication leads or your executive board director champion, and it gives an honest snapshot of where you are, but also an improvement plan of where you might want to be. I'll leave that there for now, just in case anybody else wants to talk about it later, but I'd be happy to talk about it more in the break. I'm on my last couple of slides. So I just kind of want to end on a couple of things. So I spoke about consensus at the beginning. And one of the things which is tucked away on the CQC website, but when you actually read the contents of it, and you look at the way the arguments have been formulated from a CQC perspective, the brief guide for inspectors is something which is well worth a read, because in a handful of pages, maybe 3 pages, it outlines the CQC's position. Now, it's a guide for inspectors, but that doesn't necessarily mean it's something that only inspectors can use. And I've just kind of copied and pasted the introductory few paragraphs which set the context there, but I won't read them for the sake of time. Last but one slide, just kind of recapping on what I've said already. If we sit on our hands and do nothing, chances are smoking prevalence is going to remain stubbornly high, and as it is, and inequality is going to widen. There's clearly a need for urgent action. There's clearly precedents where England and the UK have been global leaders in tobacco control and public health more broadly. So the status quo, I would strongly argue, from my position, as you would expect, is not acceptable, in the sense that if we do not urgently address this, we will have failed a whole population. If we accelerate marginally, and this is taken from the Stolen Years report, a slight acceleration will get us to similar reductions to the general population by 2055. So that says in line with a routine and manual population where smoking prevalence is already significantly lower. But what we would need to really, really reduce inequalities to get to the same level by 2035, which even still is some way down the road, is an incredibly steep decline, which would need cross-cutting evidence-based action across the system. And this is not me saying, now over to you. You know, there are things that we are doing at a national level where we think some progress has been made, but clearly there are gaps which we want to address, data being probably the most pressing priority which needs urgently addressing. So I will leave you with that for now, other than just to very quickly mention that some of you might be aware of the Mental Health and Smoking Partnership group, a group that of academics, clinicians, service user representation, a coalition of individuals and organisations that have come together post the Stolen Years report. They, I believe, are hyperlinked. If they're not hyperlinked on my slide, their website is there's a wealth of resources on there. There are webinars, videos of other trust experiences. But what they are currently in the process of doing is mailing every single mental health trust in England their new suite of resources. So these are shared key messages, position statements, guides, and posters and things like that. So you should expect these resources to land next week, I'm told. And that's me. Thank you.